Can I invite Dr. Ravi Bathina, who is going to talk about non-invasive FFR. As you know, there's a lot of interest on non-invasive FFR and whether it will replace the invasive FFR. We need to find out. Thank you, Dr. Ravi.
Good morning. Dr. Rath and Chairman, thank you very much, and Srinivas and his associates here for having me here this morning. My goal in the next 15 minutes is to introduce, I'm not sure how many of you are familiar with non-invasive FFR. So what I'm going to present is, will it be a clinical reality? If so, how soon? Actually, my life is made easy this morning because the first speaker has given a wonderful talk about FFR, so I don't have to dwell too much to emphasize the importance of invasive FFR as a gold standard for our interventional work. So after having said that, I had to acknowledge these people. Most of my data is acquired from these people, and there is this institute in Redwood City, California, called Heart Flow Technologies. They are the prime movers of this new, innovative, non-invasive FFR. And Dr. James Min, I'm sure most of you know, he is now in Cedars-Sinai. He is one of the medical advisors for this FFR technology. Incidentally, James Min was president of Society of Cardiac CT till 3 weeks ago. Outline of my talk will be role of invasive FFR in interventional practice, which I won't dwell much now after I heard the first speaker. Then the very fact that there's such a new technology, I want to spend few minutes on the technological aspects of FFR CT, so-called non-invasive FFR. And we'll talk about two important studies which validate the efficacy of non-invasive FFR. And we'll see a couple of case examples. And then we'll talk about present state of research and presence of this FFR CT in the market. Then I'll leave the answer for you people whether FFR CT is a reality or not. What is FFR CT? It is non-invasive FFR computed from regular coronary CT scans, non-invasive coronary scans. You know, here there are two examples, two patients, intermediate lesions. Only one of them needs intervention because of functional abnormality. All through the years, we are used to non-invasive tests which don't measure the lesion-specific ischemia. They don't compare anywhere to invasive FFR. I don't think there's any argument here that invasive FFR is the gold standard for functional assessment of a given lesion. Look at our previous, our most used technologies, non-invasive. Not the greatest sensitivities or specificities. Again, point here is the gold standard is invasive FFR. If only we can get the FFR without invasion, that will be dream come true. As Ajit was mentioning, more than half of the lesions with CTA, stenosis, more than 50%, are not functionally significant, do not cause ischemia, and yet we tend to intervene and put stents. Same story with invasive angiography. The intermediate group, the first one, actually the first speaker showed this slide, more than 65% have negative FFR and we intervene. If only we can judge and precisely know which lesions need to be intervened, that will be the greatest boon for our practice. I won't go too much on this because the first speaker already shown on this, and as you can see, this particular part of the slide, angio-guided PCI versus the FFR-guided PCI. There is almost 33% of reduction of risk of death and MI in patients who undergo FFR-guided PCI. There is no discussion about it. The first study already, the first speaker spent a lot of time. It says stenting on non-ischemic segments does not improve the outcomes. Now, if we can have CTA, if we can use non-invasively to diagnose functionally significant coronary stenosis, that will be the best thing we can have. Now, I'll spend a few minutes on FFR technology. The buzzword for non-invasive FFR is computational fluid dynamics. It sounds crazy. All that it says is the fluid dynamics are computed and then arrive at some simulation. So once you get this, we can have the answers from usual normal acquired CTA. There is no additional imaging required, no modification of our usual protocols when you do CTA, and there is no need of administration of vasodilators, etc. Sounds like magic. But it is based on very solid scientific principles. Number one, coronary flow is proportional to myocardial mass at rest. Q is proportional to myocardial mass at rest. Number two, coronary arteries, they are dynamic. They remodel in response to the amount of fluid that they carry, and smaller the arteries, they have higher resistance for their blood flow. Fact number three, whenever there is hypoxia, there is intrinsic adenosine secretion and then there is vasodilatation. So based on these principles, now don't ask me about this slide, these are all well documented blood flow dynamics for the past, I believe, 1.5 years. But we could never use these technologies, these equations, because we didn't have the supercomputers. Only now the solutions of these equations are possible because of development of digital computerization and numerical methods and supercomputers. In addition to these things, in calculating the FFR non-invasively, the following pathophysiological variables are taken into consideration: gradient across the stenosis, velocity across the stenosis, myocardial mass in lesion-specific segment, and microvascular resistance, and more important, blood viscosity. All these factors are figured in to calculate the non-invasive FFR CT. So first you take a 3D model, anatomic model of coronary CTA, and then we figure in the pathophysiological aspects we talked about, and the whole data is passed through the supercomputers, which calculates the hemodynamics, and then finally we arrive at 3D FFR CT, which is computed. It's simply put, this is the throughput. It's a web-based technology. All that we do is we do your CT scan. Oops. What did I do? Okay. I guess. Yeah. Okay. So we do your CT scan and then transport the images to the core lab. There to do all the computation and get the answers using this fluid dynamics and send you back the results. That way you can act on depending on the FFR CT. Well, sounds like a fairy tale, but there is definite clinical validation of this non-invasive FFR CT. There is, in 2011, there is a study published called Discover Flow, And this was called, this was nominated as the best innovative award last year Euro PCR. This study was published in JACC of November 2011. The study design was a prospective multi-center study. Participating centers are very highly acclaimed centers, a lot of them from Far East, and also Stanford University, and then from New York, Dr. James Min. What did they find? There's some examples here. On the top panel, there is an intermediate lesion here. You do a FFR CT, non-invasive, 0.74, so it's ischemic. Then we do invasive procedure and check the FFR invasively, and it correlates very well. So non-invasive FFR CT and invasive FFR CT are correlating well in this particular case. Similar example, a lesion in the OM or circumflex territory. There is intermediate stenosis here. We do non-invasive FFR CT, 0.85, no ischemia. Next step, invasively you do the same thing. It matches very well. Sounds too good. Also, this slide very clearly depicts, compared to the invasive FFR and non-invasive FFR, anything beyond 0.8, as we all know, it's non-ischemic. What we found is there are very, very few false positives and very few negatives. So indicating that both these modalities go hand in hand. This slide very clearly tells invasive FFR and non-invasive FFR, the delta is only 0.02. They correlate very well. Again, this is the diagnostic performance of non-invasive FFR CT compared to cardiac CT alone. In cardiac CT, we find, let us say, intermediate lesion. How does it compare with FFR CT? The best thing is here. The red one is the non-invasive CT scan, and the blue is the FFR CT. Accuracy significantly improves. Specificity almost twice. So FFR CT in conjunction with non-invasive CT can help us quite a bit. Again, the same thing. If you do a CT, yeah, here you go. The same study, discovery flow, another subset was studied. This is the non-invasive CTA, and this is the FFR CT, non-invasive FFR CT. There are about 38% of false positives in non-invasive CTA. In FFR CT, 11% false positives. If only we can add FFR CT to the CTA, there is threefold reduction in false positives. Tremendous. Another aspect of the study subset was looked up, and what is this study? This part looked at what is the accuracy of FFR CT. Is it superior to CT alone when there are some adverse factors? Namely, for example, this one is the non-invasive CT. This is non-invasive FFR CT. In the presence of adverse factors like increased heart rate, high calcium, motion artifacts, poor opacification with the dye, in all these instances, the CTA puts very poorly compared to FFR CT. And accuracy jumps from 65% to 80%. Specificity from 24 to 81. The point of the slide is FFR CT is relatively immune to the adverse factors that we see in a regular CT scan. Conclusions? FFR CT is a novel, non-invasive method that enables physiological determination of coronary artery disease from regular CTA without any additional imaging or medications. This prospective multi-center study showed FFR CT demonstrated excellent correlation with invasively measured FFR. FFR CT was superior to CT for diagnosis of lesion-specific ischemia, threefold reduction in false positives and twofold increase in true negatives. The next trial is de facto trial. This is a 17-center international study of 250 patients undergoing CTA and also invasive FFR to evaluate the diagnostic performance of non-invasive FFR CT. Results of this study will be presented in about 2-3 weeks from now in European Society of Cardiology meetings, August 26th in Munich. I was talking to some of the researchers last week in Baltimore. We had a Society of Cardiac CT meeting last week, 10 days ago. These people are very gung-ho about it. They think it will fly well. In fact, they are waiting for the study. Then they are going to apply for FDA approval in USA. As of now, it's already working, approved in Europe. I'll show a few slides, for example, and then I'll be done. Srinivas, 5 minutes, okay? Yeah. So, are these lesions functionally significant? Does this lesion cause ischemia? There is some disease here in the distal main and then proximal LAD. You do a cath, invasive cath. Is it significant? Well, let us see. Let us do an FFR, 0.74. It's an ischemic causing lesion. Non-invasive FFR CT correlates very well. Next patient. Does this lesion cause ischemia in the RCA? Let's take a closer look. There is a mixed plaque, calcium, soft plaque, and still we see some amount of dye flowing through. So it could be intermediate lesion. Let us check it out. Do an invasive cath, questionable, FFR 0.94. So it's non-ischemic. We could simply get this information by non-invasive FFR. Does this lesion cause ischemia? Mid-RCA, intermediate lesion. Is it significant clinically? 0.89, non-ischemic. Non-invasive FFR CT, no sweat, correlates well with invasive FFR. So these are some more examples of intermediate lesions which correlate well with invasive FFR. The diagnostic performance of non-invasive FFR CT for intermediate stenosis, negative predictive value is 91%, sensitivity is 90%, very acceptable. This point I want to drive home. The other functional tests we are doing all through, they reach a per patient accuracy, whereas perfusion techniques, SPECT scan and so on, they can give us per vessel accuracy. Whereas FFR CT, either invasive or non-invasive, they can give you per segment accuracy. We can check the resistance at every segment of the coronary artery. That is really useful. Another exciting thing they are talking about. Basically, gentlemen and ladies, this is a very new technology. I believe personally we need more tests and more patients evaluation before it can take to mainstream, but it's very, very promising. Look at this innovation. Look at this FFR CT and virtual stenting. So you do a 3D computational model, you get FFR CT calculated, and then computational model is modified to restore the area of treated coronary segment, that is virtual stenting, and then see how it works. This is an example. You do CT-derived FFR CT, 0.72. You do an invasive angiogram and invasive FFR. Depending on that, we stented this patient, and FFR got better. Same thing, 0.86. So,
Heart flow is developing for the first time, a non-invasive way to measure how specific narrowings in a patient's coronary arteries impact blood flow within their heart. This metric, called fractional flow reserve, or FFR, is calculated with a 3D model of an individual patient's heart created from that patient's CT scan images. Physicians can rotate and magnify the model to see each coronary artery individually. By clicking on a specific point in the coronary artery, the physician can view the FFR measurement at that point and compare it to other points in the coronary artery. In the future, HeartFlow's technology could also be used to model the effect of stent placement in specific coronary lesions. Physicians will be able to test placement of different stents in multiple lesions and model changes in blood flow to assist in planning the optimal treatment for a patient before performing an interventional procedure. In this simulation, the stent used to dilate the narrowing in this patient's artery would increase blood flow substantially. HeartFlow.
So we can predict the therapeutic benefits before intervention. So I thought, because of lack of time, I had few FAQs. How could FFR-CT provide better results than coronary CTA alone, since it's using the same anatomic data? That's a relevant question. Answer is, FFR-CT technology incorporates more complete anatomic model and also leverages the physical loss of blood flow and established principles of coronary physiology. So we can get good outcomes. Number two, are the coronary CT scans performed with adenosine? No. Standard coronary CT scans are used to build heart flow models. Hyperemia is simulated using known vasodilatory response to adenosine. Does microcirculatory disease or scar tissue affect non-invasive FFR? It may, but this is factored into models since the epicardial coronary arteries remodel in response to elevated microcirculatory resistance and reduced flow. Can low-dose coronary CT scans be used for FFR-CT? Because nowadays, everybody is talking about CT scans, how to reduce the radiation dose. So if you do a low-dose coronary CTS, when we started coronary CTS, we are using almost 12 to 15 millisieverts. Now we have come down to sub-millisievert. Most of the time in our center, we are doing at 2 to 2.5 millisieverts. So with those low-dose CTS, can we get FFR-CT? Yes. Any coronary CTA protocol that results in good quality of coronary arteries is fine to get FFR-CT non-invasively. Can FFR-CT analysis be performed in patients with calcified arteries? Yes, provided that there is a coronary lumen that can be seen. In summary, ladies and gentlemen, HeartFlow FFR-CT analysis provides a non-invasive assessment of computed fractional flow reserve based on cardiac scan data. FFR-CT provides physician with information on the functional significance of coronary lesions and helps the physician select patients for further invasive evaluation and treatment. Thank you.
Thank you, Dr. Bathina, for the excellent presentation and enlightening us with this new methodology, which certainly looks promising.